12th is space leave. But they didn't give a good reply. मतलब पहले जानना क्लिनिकल एनालिसिस से हो जाता था. उन्होंने point by point rebuttal किया. कोई rebuttal नहीं.
सबमिशन में कुछ मेल नहीं आया था.
हाँ, वो सबने देखते नहीं है सर.
Start?
Yes.
इनके जो थीसिस के टॉपिक्स होंगे, let them choose the areas. उनका समाधान उस एरिया का. स्पेसिफिक एरिया करके आप लोग सोचिए.
Good afternoon, everyone. The moderator for today's case conference is Dr. Costa. I'm presenting the case of a 36-year-old Muslim female who is fourth in order out of four siblings, a graduate who has done her BA, a housewife, divorced in 2015, then remarried 3 years back, belonging to middle-class socio-economic status, mother to two children, living in a nuclear family and a resident of Dehradun, admitted to the hospital on the 30th of May, 2022. The informants are her husband, a 45-year-old male, who has studied till class 10 and is a construction site contractor, not present with the patient throughout her course of illness. The second informant is a 49-year-old brother who is also a contractor and was also not present with the patient throughout the course of the illness. And the third informant is the patient herself. The history given is clear, coherent, but inconsistent, not given in a chronological order. History is reliable but inadequate. The birth, childhood, pre-morbid personality history are unavailable. Treatment history, the records are also unavailable, incomplete. The chief complaints are self-muttering, self-smiling, hearing voices not heard by others, both for 14 years, increased sleep for the past 10 years, urinary incontinence for the past 2.5 months. The complaints are insidious in onset, continuous in nature with a deteriorating course. The patient was apparently well 14 years back when there first started occurring issues of increased arguments between the patient and her husband, and they were initially brought to the notice of the family members. There were also increased episodes of discord between them, the patient and her in-law, especially her sister-in-law. The informant, her brother, said that the patient's first husband saw her first smiling to herself whilst cooking on several occasions. On inquiring about the same, she would initially refute it, but then reported of hearing a voice when she was all by herself in the house. She further reported that she would hear the voice of a man who would talk directly to her, saying "Abbe yaar," whenever she would be doing any work. For example, if she would be sweeping or cooking, or she would hear the voice saying "Abbe yaar" or "Abbe yaar fir se shuru." Thereafter, she reported that initially she would hear the voice fleetingly once or twice in a day, and that too only whilst working. But then she started hearing it more frequently, even when she was talking to other people. Now the voice would say to her कि ये तू किस तरह से काम कर रही है, ये किस तरह से बात कर रही है, ये क्या तरीका है बात करने का, अच्छे से बैठ, etc. The patient reported that she was subsequently taken for treatment for the same, but reported no improvement in her complaints as the patient was non-compliant to treatment. On one occasion, she suspected whether it could be her sister-in-law who is the reason for this and has left an entity in her pursuit. Now, due to this increased discord between the family members, her husband filed for divorce. It was during this time that the patient even attacked her sister-in-law, allegedly trying to strangle her, blaming her for it all. During the course of these divorce proceedings, the patient's brother reported of an increase in her complaints, wherein she on various occasions would urinate in her clothes and would say कि वो मेरी पेशाब निकाल देता है. But this would occur only when the patient was laughing out loud or was being tickled by someone. Then the patient's divorce was then finalized 7 years back, after which she and her 6-year-old daughter came back to live with her parents. She subsequently reported an increase in her complaints, wherein now she would report of a further increase in these frequency of hearing voices, which at which point she would often have to get verbally abusive and say, "Mera पीछा क्यों नहीं छोड़ रहा है? मुझे माफ कर." She was taken to several faith healers for the same, who made them believe that this is the doing of an entity called Zahir, who was probably a former flame of the patient and was allegedly seeking some sort of a revenge. The patient was again taken to a mental health specialist, but the treatment was not followed up regularly. Now the patient married for a second time in 2019, left her firstborn daughter at her parents' house. The husband initially reported no behavioral abnormalities during the first 2 weeks, but then reported of lethargy in the patient. He reported that even whilst sweeping the floors, she would move the broom with a very light hand over the floor, leaving most of the dirt behind. He also noticed that she would on occasion put either too much or very little salt in the food. Citing these issues, he asked her why she would be so lethargic and not work with more zeal, to which she would say कि मैं बहुत थकी हुई हूँ, मुझसे ज्यादा बात मत करो. He consulted her family members, but they also paid no heed to it. The patient's husband subsequently resorted to doing the household work all by himself. The husband also started noticing that she would, on various occasions, laugh out loudly or start cursing at her own behest, after which she reported to him about her symptoms of hearing voices. At this point, the patient now reported that she would be unable to get out of bed, as she would say कि वो मेरी कमर तोड़ रहा है, मैं उठ भी नहीं पा रही हूँ. In the meanwhile, the patient delivered her second child, a son, in 2021, for which she was admitted in the hospital for 7 days. In the hospital, the patient would feed the child, but after getting discharged, her husband noticed a change in her attitude towards the child, wherein she would leave the child crying and refuse to even feed or change the diaper of the child, all the while saying, मैं अपना ध्यान तो नहीं रख पा रही हूँ, इसका क्या रखूंगी. She would also not handle the child gently and would be very rough whilst handling him. She reported that whenever she was wiping the child's, she was cleaning the child's diaper, the voice would tell her कि जा इसकी गू ही खा ले. After the first month of the birth, when she was reluctantly, after some point of time, when she would even try to change the diaper of the child, the voice would tell her कि जा इसकी गू ही खा ले. After the first month of the birth, she went back to her parents' house, but to no avail. The husband had to then eventually give their son away to a relative for a few months, all the while the patient now reporting of a further increase in her symptoms, to the extent that she would have to sometimes keep her hands on her ears to make the voices stop. And now she would report that not just her back but also her hands are hurting, as wo mujhe maar raha hai. During this time, the patient now also started suspecting that people around her are talking about her, poking fun at her, wherein she would report कि वो मुझे देखकर चम्मच बजा रहा है. And subsequently, whenever there would be a noise of vessels clanging together, she would get alert, suspecting that maybe she's being talked about. Also, during this time, the patient discontinued her treatment on her own accord and again reported of complaints of micturating in her clothes. Even if she would have a cough or sneeze, she would go on to say कि वो ही करा रहा है ये सब. At this point, the content of the voices had now become even more profane, saying जा अपने भाई के साथ ही जाकर सो जा, या जा अपने बाप के साथ ही जाकर सो जा. Henceforth, there were increased episodes of irritability, anger outbursts, increased quarrels with the husband, wherein she would start throwing things at him. Citing this aggressive behavior, she was brought to the hospital for admission. Negative history: no history of thoughts being introduced into mind by an external agency against the will. No history of disorganized behavior. No history of own thoughts being known to others against will. No history of sustained over cheerfulness, over religiosity, over familiarity, big planning, or over grooming. No history suggestive of pervasive, persistent low mood, decreased self-confidence, recurrent crying spells associated with suicidal ideation or even an attempt. No history suggestive of any repetitive thoughts or compulsive acts. No history of any head injury, loss of consciousness, abnormal body movements associated with incontinence, tongue bite, frothing from mouth, uprolling of eyeballs, blurring of vision or double vision. No history of any substance abuse. No history of any hypertension, diabetes, mellitus.
Complaints like back pain or sort of we have found a medical reason behind it. So can we call it a made effect, or because she is not able to say कि how is he doing that? She is just saying कि मैं कर वो करवा रहा हूँ.
Mental status history, she is saying that she's attributing it to those to someone who is doing this.
Yes.
You are saying that you are saying that it is medical reason. What attribution is to towards someone doing it?
So this is according to the history, the question that Dr. Ayushi asked. So that is valid up to an extent because although we will be clarifying it later,
Patient's attribution is to medical illness or something?
no, the voice.
But you are saying that medical illness
So we are attributing it.
patient attribute to the
No.
first marriage, how much time she was lucid?
So this is the little inadequacy and discrepancy that we are not able to.
What time she got married?
Sir, in 2000, so before 2015, sir, her child right now is 15 years.
The first marriage. First. Child, so
Her ages,
Mhm.
ages,
Her age is 39 years old.
eldest child,
Eldest child is right now 14 years old.
she would have married in 22, 23. And the illness started before that or not? We don't know.
Before,
Further-
so
further?
we just know that the brother is saying that it started like 14 years back, but the patient is saying that the illness was 1 or 2 years before her divorce, which was 10 years back.
Before the marriage.
So before the marriage, sir, they are saying that no such complaints were present.
Everything started after marriage. How
Yes.
much time after marriage? You
How much time after marriage, we are a little unsure. Child was born right one year after the.
history is inconsistent.
Yes.
So are you saying that it is saying that it is reliable?
So reliable in terms of the 3 years that we have.
Duration of illness, how much you are saying?
Overall duration of illness, I'm
The
saying is
history-
14 years,
The history is 14
according to the brother.
years. So in 14 years of history, you're
We've
saying
got in 3 years.
history is reliable.
Yes.
So either you say 3 years history is reliable, and prior than that is not reliable.
Yes.
You can demarcate that, or otherwise you can say the 14 years history is not reliable.
So the chain of events we are a
You're
little
saying those
unsure
two
of.
repetitive thoughts. What do you mean by those? She must be having all these preoccupations. So repetitive thoughts.
Qualify them. To which kind of
Sir, any one kind of a thought which is distressing and which is ego dystonic.
Discussing behavior. So it's simply intrusive, dystonic, irrational. वो थोड़ा सा जब जानेंगे then you are actually ruling out a group of things. Okay. And her content has things which are not pleasing. ये कर ले, वो कर ले, ये खा ले. So persecutory theme, content में theme.
So just 1 or 2 instances.
Otherwise, things which are spoken to her are always derogatory.
Yes.
And her persistent pervasive mood.
All throughout the illness, sir, it's irritable, sir.
When you're saying there's no history of any crime or persistent crime. So she has never got emotional out of her pain.
So because at times, when she bursts out laughing and all of that, so she says that the voice has cracked a joke or something. And she feels that this is, I feel that somewhere or the other, maybe she feels a little connected to her previous husband because she says that.
Because history is not
This-
generally what people present, they come abruptly to an end. That for this reason, patient was go to the hospital. it should be avoided. पता नहीं कहाँ से intuition आया है. And then when you give us a crux of the history, before negative history, you should always end it with persistent pervasive mood and how it has impacted the activities of the day. In terms of our work, recreation activities, and relationships. Team moments में how this has affected her. Most of many things in your history is there where you actually explain, but this has now one divorce has happened. And her ability to work in the home. And starting of the illness becomes very important.
Yes.
Starting of the illness, we don't have that kind of thing. How it started. That becomes very important to tease out. So this becomes a little incomplete in that sense. Anything else?
She got remarried, then she was fine. She got remarried when she met the guy.
She did not tell the family members or the patient herself. They did not tell him about this. And whenever I've mentioned this in the history, whenever he used to ask her why you so lethargic, then she used to say that don't talk to me. But there was never. So during the in the second pregnancy, so she was on medication and she was taking only one tablet for that.
The illness, did it?
Yes, sir. Like her husband reported that even any kind of a fetal movement or anything, she would never report of the same. She was very callous about her entire pregnancy, and she was not very. Yes, she was not. Matlab, medications वगैरह, she was not very compliant to that also.
That could have been shared in the history. It's a very significant point. So important physiological event. Basically, this inability to report these fetal movements. This shows that disability was or impairment is very significant. This is important. And the voices were there throughout the pregnancy.
Yes.
Have you ruled out epilepsy in history?
So there is no history as such of any abnormal body movements.
Could this be dyscognitive seizures? Where she is hallucinating voices, which are part of the seizures.
But so for so long, so if and consistently present, continuously present.
So anything else you would like to rule out in negative history? You said loss of consciousness is not there. Is there anything else?
Rigidity of
कुछ complex partial seizures में rigidity मिलता है. The part of CPS, the part of automatisms. So automatisms, ऐसे seizures आएंगे नहीं तो ये because she has this laughter के बाद एक illumination वाला phenomenon. So does it happen in epilepsy? Epilepsy. So खूब आदमी हंसता है, फिर illumination हो जाता है. The knee slowly falls. The last sentence.
so treatment history. The treatment history, that is, the records are only available from May 2021 to August 2021, where she delivered in March 2021, after which her medication was continued. And she was kept on one medication all throughout her pregnancy. Again, the records are unavailable. From May, she was started on tablet clozapine, 100 milligrams in 2 divided doses, imisulpride, 100 milligrams in a single dose, which was increased up to 200 milligram. Then in the month of June 2021, clozapine was continued as the same, but instead of imisulpride, paliperidone 6 milligram in a single dose was started, and alprazolam and a combination of alprazolam and propranolol was started, 0.25 and 20 milligrams respectively. Then clozapine was again continued throughout the month of July. Paliperidone, the dose was increased up to now 12 milligrams in 2 divided doses. Alprazolam, propranolol were continued as such, and buspirone was added 10 milligrams in 2 divided doses. Clozapine was again continued in the month of August. Now, Lurasidone 80 milligram was started, and this was continued in the month of August. Since August, she has left treatment. In the months of May to August, we have seen improvement in the complaints, but not to the extent that the child could have been brought back home because she was refusing to take care of the child. So, and the voices as reported by the patients were still present.
Is for the speaking will also come
Fa-
treatment history, and then summarization of the treatment history. Any drug in adequate trial first, and then whatever improvements were. So the summary 2 to 3 lines will do this. And oral compliance. What is your impression? Is she compliant or not? These are for both compliance. Side effects or anything else.
It has been seen that from May to August, since she was taking clozapine, response was seen. A good response
Last
was seen. Sorry, sir.
Last year
Yes.
when she was pregnant
Yes. After delivery.
after delivery.
Yes. 200 तक गया था. She did report of constipation and palpitation, but apart from that, so propranolol was started for that. Past history: the patient has 2 children. The first of the first marriage was born in 2007 via C-section. Second of the first marriage in 2021 March by C-section. There is a history of urinary incontinence even before the first delivery. Why we are calling it before the first delivery? Because the total duration of illness is 14 years according to us. So it is present before, prior to that also. And abhi 2.5 months she has again started reporting of urinary incontinence. History of irregular menstrual cycle is present, suggestive of oligomenorrhea. The LMP was on the 1st of June. Should I proceed with the family history? Family history: she is 4th in order out of 4 siblings, currently living in a nuclear family with her husband. The child is living with a relative right now. History of demise of father in 2017. Mother is a known case of diabetes mellitus. And history suggestive of psychosis in one paternal aunt who was left to live at Jaipur since 30 years.
Why the husband is also divorced?
No, he was a friend of the family.
Generally, marrying someone who has had a divorce in the society is little stigmatized.
Yes.
So he agreed vividly.
Why? Because the patient is a graduate and she is educated, but he is studied till only class 9.
The father of this patient is the teacher of the husband, second husband.
Did they report the illness? to the
No.
husband?
No.
Then you clarified this.
Yes, sir, I have written it in the history also that they paid no heed to it.
Srinivas, emotional involvement with the family.
She was left at Ajmer Dargah Sharif to live there with complaints suggestive of Bua.
Patients do that.
Yes, suggestive of psychosis. So she was sent to live there only, and she's living there by herself at the Dargah. The elders of the family, her father, her father's brothers.
And she is living there.
Yes,
Peacefully.
not peacefully outside the Dargah.
She's there. She's
She's alive. She's alive.
physically okay.
Physically okay, but only to the extent that she has to beg and all over there for. But the family has cut their ties.
So when we talk about families, we talk about primary, secondary, tertiary support. So whether in this case, she has adequate primary, secondary, tertiary support.
No, sir. despite her brothers growing up with her brothers and everything, they have not been present throughout the course of the illness. They are giving inadequate history, and she herself, when we inquired about the paternal aunt, she herself got a little aggressive कि उससे कोई ताल्लुकात नहीं है हमारा. She refused to talk about the paternal aunt, the patient.
Attitude of the family towards her illness.
Attitude of the family towards her illness, sir, can be considered as careless, because when she got divorced, तो फिर regular follow-ups नहीं हुए. उसके बाद she was being treated in Delhi. There are no previous records of her treatment, and she was not even followed up, even if to a new place, but she was not taken to any hospital or medical facility. They would always contribute it or attribute it to.
Insanity.
Good.
Now they say that promote intercaste marriages because of Agarwal mutation. So that's easy. Children made is coming Agarwal mutation. Because of Agarwal's, I belong to the community. Because of the family, the genes assorting very closely, the rare mutation is a community. They say promoting segregated. So insanity. So these all should come in your family history. The family history is not only merely presence of respiratory disease, the attitude, the support system, and then the whole domain of the family. Who is the decision maker in their family? Is the husband decision maker or the patient decision maker? It is an autocratic system or a democratic system of decision making. Am I right?
Yes. Mostly an autocratic system, sir, and yes. Yes.
What about their social responsibility? Yes. Are rules to find how the boundaries are the permeable, semi-permeable, rigid boundaries? Yes, sir.
The birth, childhood, adolescent, pre-morbid personality history inadequate. The only thing that we could get from birth history was she was a full-term normal vaginal delivery, home birth. The birth weight we could not know, but we only know that she was not an low birth weight baby. And there is also no history of any ICU admission. Apart from that, we could not get any other history. In general physical examination, she is an endomorphic.
What class?
Yes. So she is a graduate, sir.
How was the
Bachelor.
relationship with the peers that I think she could have proved? How was the relationship? If you forget about childhood history, her school history, whatever she can say,
Yes.
any vocational history, and sexual history. So all these things, then there is something on a general pattern of living, any legal history. So whatever it is, then you not available, then you have to submitting wise and you will tell what you asked, what was the response. Then coming to pre-morbid history. Not available. So सारा section में हो गया.
So they did not.
Pre-morbid will be difficult. So physical examination.
So she was an endomorphic built female. Weight 78, height 155 centimeters, and a BMI of 34, making her a class 1 obese. And so blood pressure and pulse and everything was within normal limits. Only finding that we could find was pallor was present, which was checked in the palms and the lower palpebral conjunctiva. Then systemic examination, so bilateral air entry was present in the respiratory system. No, sir. So no physical anemia.
Even when you correlate blood reports.
According to the blood reports also, hemoglobin is 11.6.
What's that?
So after that, like,
History that we Was that also the attribution to the immediate which she was saying? That dispute that-
I don't think we can say that in psychosis always. We've had
What we
decreased sleep.
normally have seen is
But
what I'm asking is what the patient
normally
had-
we've seen that in mania that there is decreased need for sleep. But in this case, the reason that she has been given for increased sleep, or maybe we can say increased habit of laying down, is that she ki wo mujhe meri kamar tod raha hai. She is attributing it to the voice. That I'm not able to get up because I have back pain, and I have pain all over my body, and the voice is the one causing that pain. So,
UPC means in the night or in the day?
all throughout the day, sir.
In the night.
Yes, sir. There were no sleep disturbances. But there were no variations about it, sir.
Somebody
No, sir.
at night is too much. Any instances of any respiratory issues, gaps in respiration while sleeping is one example.
Should I progress with you?
So the sleep fluctuated with medications. Close-up is और बढ़ गई, close-up इनके बिना कम हो, मतलब थोड़ा कम हुआ. Whether this kind of a thing was there with sleep?
So sleep per se during the beginning of the illness, so what I got was that it's not per se sleep. She would just like to lay down the entire day, not wanting to get out of bed, which would somewhere or the other be considered as increased sleep. But that was mostly her being lethargic.
Will you complain of increasing sleep?
Yes, from the past 3 years, the husband has reported that there has been increased sleep. That she would sleep all throughout the day, and even at night would not complain of any frequent awakenings or having any nightmares of any such thing. But she would just sleep all throughout the day. These
Maybe you could have clarified it, meaning IDA, not working, indifferent, those kind of things. So history में वो आया था ये sleep वाला?
just the fact that she would lay down the entire day feeling having
Because
back
the
ache.
chief complaint है तो history section उसको जाएगा.
Yes.
So probably she won't.
She's an endomorphic built female, entered the room unaided with a bilateral wide arm swing gait, sat on the chair provided, did not return the interviewer's greetings, initiated and maintained eye contact and had a staring gaze towards the interviewer, but at the same time was also scanning the room, sat down with slightly drooped shoulders, dusky complexion, hair tied in a single plait, wearing a salwar kameez appropriate as per surroundings, had chipped nails, appeared as per stated age, appeared to be in touch with her surroundings. The attitude was evasive, but became guarded as soon as the husband walked in. So subsequently, the husband was sent outside during the course of the interview. The rapport could not be established. Psychomotor activity was normal, but during times in between the interview, the patient would burst out laughing. Speech was normal in tone, volume, intensity, clear, coherent, comprehensible with a normal reaction time and goal directed. The attention was arousable. It was assessed using the TAP test. It was ill sustained, wherein it was firstly asked to dictate the months of the year in reverse, which she could not, but subsequently she could tell the days of the week in reverse. She was oriented to time, place, and person. In general information, her comprehension was intact, vocabulary was intact. Calculation, she could do 40 minus 3 up to 2 places with difficulty. In intelligence, she could tell the the Prime Minister and the Chief Minister of Uttar Pradesh. Affect was irritable. Depth was shallow. It was constricted with a restricted range, was non-communicable. Before coming to thought, there is a verbatim. Should I proceed to the verbatim? क्या आपको लगता है कि जबरदस्ती आपके मन में विचार डाले जा रहे हैं जो आपको विश्वास है कि आपके नहीं है? नहीं, मेरे मन में मेरे अलावा किसी और के विचार क्यों होंगे? क्या विचार आपके मन में क्या आप उन्हें सुन भी सकती हैं जो विचार आपके मन में आते हैं? नहीं। क्या ऐसा लगता है कि आसपास खड़े लोग आपके मन के विचार सुन पाते हैं? नहीं, ऐसा भी नहीं होता। क्या ऐसा होता है कि एकदम मन में विचार आना बंद हो जाते हैं? ऐसा भी नहीं होता। क्या बिना बताए आपकी मन की बात कोई जान लेता है? हाँ, अबरार। अब वो कुछ ना कुछ बोलता ही रहता है कि मैं कब कहाँ जा रही हूँ वगैरह। क्या कानों में कोई आवाज सी सुनाई देती है? हाँ, एक इंसान की। वो मर्द है या औरत? मर्द है। अबरार नाम है उसका। ये मेरे पहले पति को भी आती थी, शायद उसी ने छोड़ी हो मेरे पीछे। आवाज बोलती क्या है? बहुत कुछ, जैसे कि गंदी बातें, जैसे कि अपने भाई के साथ जाकर सो जा, अपने भाई के साथ, अपने बाप के साथ सो जा। मैं जो भी बोलती हूँ उस पर कमेंट बाजी करता रहता है। द पेशेंट नाउ लाफ्ड आउट लाउड। देन आई आस्क्ड हर सब्सिक्वेंटली, क्यों हंस रही हो? बस ऐसे ही। अरे बताओ क्यों हंस रही हो? जोक सुना रहा है। अबरार जोक सुना रहा है, जैसे कपिल शर्मा सुनाता है ना, वैसे ही। नाम भी पुकारता है आपका? हाँ, बहुत बार। क्या ऐसा लगता है कि कई आवाजें हैं या एक, सिर्फ एक? क्या ये आवाज आपसे सीधा बात करती है या आपके बारे में बात करती है? मुझसे सीधा बात करती है। क्या ये आवाज आपको कोई हुक्म भी देती है? देता भी है तो मैं करती थोड़ी ना हूँ वैसे। क्या आप भी उनसे बातचीत कर लेते हैं? मैं तो उसको गाली सुनाती हूँ ताकि वो चुप हो जाए या फिर चला ही जाए। जब यह आवाज आती है तब आप नींद में तो नहीं होती हो? अरे नहीं, पूरे दिन भर आती रहती है। क्या किसी और को भी आती है यह आवाज? नहीं, सिर्फ मुझे आती है। सो on the basis of this, the stream was normal, possession was self, no formal thought disorder could be elicited, and perceptions are second degree auditory hallucination.
Content or content.
Preoccupation with the voice.
Voices.
We tried to clarify that. So the first point in favor of that is that it was occurring even before the first delivery, which was 1 year after the marriage. So it happened before also. Then secondly, that whenever she used to laugh, and the husband has also seen that when he used to tickle her or whatever, she herself used to say कि मेरा पेशाब निकल जाएगा, इतना जोर से गुदगुदी मत करो. And then subsequently 4 to 5 drops of urine would on occasion
He wants to
come.
probably ask is what about the phenomena of these physiological changes, and she's attributing it to those people doing it.
The मारता है and all that stuff.
पेशाब निकल जाता है, and those physical changes जो भी होते हैं,
Physical-
physiological changes.
Physiological changes. sir.
क्या क्या physical symptoms क्या क्या थे? ये कौन कराता है?
So what the explanation that she gave for this was that when she would wake up from sleeping, then she would have a pain in the back. I asked her if there was any kind of a sensation or any kind of a tactile hallucination that she would feel a slap or she would feel any kind of a hurt or something, but that was never present. Whenever she used to wake up after sleeping, only then she would report of pain in the hand or in the back. So that's why.
But you said that this incontinence episode she was attributing it to.
Yes. So similarly, so this also of the pain and everything also she is attributing to the voice.
To the voice.
Yes.
तो ये पूछा कि then whether it will come in thought. Then did you challenge it? Because
Yes, sir. So this my reasoning was this only कि क्या आपको महसूस होता है कि जैसे कोई मारता है?
कोई बोल रहा है.
हम्म.
मेरे को कुछ बदलाव हुआ, मेरा हार्ट बीट बढ़ा, तो I feel कि नहीं ये आवाज ही करा. But this is part of me thought. So whether we will slot it into some abnormal thought content, we'll give it some hierarchy or some impression there. पहले उसने आप बोला ना, वो जो कुछ कर रहा है, वो कर रहा है, इसलिए भी कर रहा है. Rather than saying whether this deserves a place in thought content, this phenomenon.
With impulses.
क्योंकि अपने आप उसको डिस्कस कर रहे हैं, तो इमोशन को डिस्कस कर रहे हैं. हम जो मेड फिनोमेना कहते हैं, we will discuss basically letting her pass or urine is basically urination till a point it's a voluntary act. After a point, you lose control, then becomes stress incontinence can voluntarily or regularly.
What was the medical cause? Medical cause.
We didn't find any medical cause.
My point point
But
is,
she is not reporting anything after that alternative is started.
so my point is whether these are misinterpretations. Physiologically, she is misinterpreting. So ideas of misinterpretations and illusions of misinterpretations and explanated illusions develop कर रही है. वो सब में शेक करेंगे तो पता चलेगा. उसका एक वर्बेटिम आना चाहिए. ठीक है. तो शायद she would have come out with other things. Why you conception होना चाहिए आप ही क्यों और क्यों नहीं, then they'll come out with all these things also.
When we asked her, sir, this ki, why you? Then she said that this used to happen with her husband also. He also used to hear these voices. And since then, she has been hearing these voices since her first marriage. And it's him who has sent these voices or this man behind her. That is her explanation for this.
If she's clearly saying कि ये सब चीजें कराता है, this is
Yes.
other psychotic phenomena कौन कर सकता है?
Judgment test is intact, social and personal are impaired, and insight is of grade 1.
That कौन सा है?
Test.
Basically, verbatim should the question should end with other modalities.
Okay.
हम एक modality exhaust कर ली है already, कि कुछ दिखाई देता है, कुछ महसूस होता है, सुनाई देता है, तो वहाँ से आपको if she says no, वहाँ पे वो end हो जाएगा. Perception का evaluation आपका end हो जाएगा. That should have been.
Professor, I would like to say that in verbatim, that this confusion is going on, verbatim how should be, there is no confusion. Basically, for thought form, you could give a neutral sample, that's all. And for thought content, for delusion and all these things, you can give procedural, you can give composite verbatim. So you have the option. But for formal thought disorders, you need to give a paragraph or two paragraphs of a neutral sample.
And at times, question answer form में नहीं किसी का पाए. Patient might be asking about, so whatever is the issue is doing, you have to go by that. You can't go by the study strategy. Many times patient might be doing a lot of things, and then just need to cue the patient in very, very small things. And that will come with only with habit. So I think she's tried to write a sample, which is credible. But if you try to interview and write it, then you will gain the habit. After some time, you may not write it and then you can recite the whole sample. Then it becomes easy because an exam, I don't know whether you get time to write the sample.
In exams also they can write question and answers.
Basically, हाँ, point है कि जो interview का flow है वो जो जैसा आया है वो वैसे लिखते.
So where do we start the questions from? Based on the symptoms of the patient that we have mentioned, based on the chief complaints, or based on how?
There is no uniformity. The patient would come, you will greet the patient, then you will ask the purpose and the issues, then where patient wants to take you, then there things will start. अगर आप thought form की बात कर रहे हैं, तो आपको neutral situation देना पड़ेगा, तो आपको examination को दिखाना पड़ेगा, तो आप neutral sample लेके दिखाएंगे. As he said, content का बात आ जाता है, तो if you have derived your content, you can fine tune it with some question answers. But आपके first years को start सारा sample लेके करना पड़ेगा, तो आप tease out कर पाएंगे. Many times you might not get a patient who has been evaluated before in exams. First evaluation होगा, you don't know, no one knows क्या होगा. But that is actually better rather than Dr. Costa or Dr. Veena telling you 3 diagnoses. You go by a biased mindset and then making mess of everything because your instincts are telling you something else and the मिलता कुछ है, दिखता कुछ है, होता कुछ है. And then जो बताया जाता है वो कुछ और होता है. And the same lines of perception, not content and perception are not different. Similar thing is there. How to frame your questions? PSC 9 is a very good reference. Scan 10 is a reference. वहां से आपको फ्रेम कैसे करना है, आपको क्वेश्चन पे वर्बटिंग क्या यूज करने हैं, not in a very strict structural sense. You can modify it a bit. That is written in those texts also, in those references also. But you need to frame it up because exam ने तो आपसे पूछ लेगा आपने कैसे frame किया. You don't know even how to frame a question. So वो important. But ऐसा नहीं कि जैसे उसमें लिखा बिल्कुल आप strictly वैसे बोलेंगे. You can fine tune it as per the patient culture, patient's education level.
DF. Index patient, 39-year-old Muslim female, divorced in 2015. Second marriage for 3 years, married, mother to 2 children, studied till BA, a graduate, fourth in order out of 4 siblings. Resident of Dehradun with history of demise of father in 2017, history of diabetes mellitus in mother, history suggestive of psychosis in paternal aunt. Presented to the OPD with complaints of self-muttering, self-smiling, hearing voices not heard by others for 14 years, increased sleep for 10 years, urinary incontinence for 2.5 months, with an evasive attitude, irritable quality of affect, and second-degree auditory hallucination, with impaired social and personal judgment, and an insight of grade 1, is kept on a provisional diagnosis of psychosis, NOS, and a first differential of schizophrenia. I am. The first thing that because comes to mind is that it's a continuous illness, and since the delusion or any kind of, we have not been able to establish that in the MSc, and neither from the history are we getting any kind of a delusion per se. We are only getting an idea or an overvalued idea that maybe this was a referential idea or maybe this was a persecutory idea, hence my first. But that was ma'am only कि हो भी सकता है नहीं भी हो सकता है. On that basis, she was not sure about it. That was on an idea level. So provisional diagnosis is of the total duration of illness.
With this information, can you make a diagnosis?
But the treatment history is inadequate, the premorbid history. We can.
इस पे अगर ठीक कर पाओ तो और किसी में से रिपीट कर पाओ. It's a clearing diagnosis. Inadequate. I don't know. Exam में तो inadequate कब होता है?
Because we don't have childhood history. So if she says it is because adequacy is for the history.
Yes.
The premorbid is not there. She has to say these is domains history we don't have. But at the same time, relevant information. Patient coming to me with 4 panic attacks in last 1 week. I have a significant amount of history to make a diagnosis of panic disorder. I might not have anything else before that. So, इसलिए I तो differ. I would differ to you if you say inadequate, but still make the diagnosis. But why second differential? That means you must be having some points against.
So because we are not able to, out of the A to D criteria, we have just gotten running. Yes.
ICD-11.
Sir, even according to ICD-11, we've only gotten the delusion part according to history. Right now on MSc, when I asked her about the husband ne choda hai part, she was in doubt about that it could have been that, and hallucination in running commentary, auditory hallucination that we've been able to get. Apart from that, so we are not getting any experience of influence, any disorganized thinking, negative symptoms, or psychomotor activity disturbance. That has only happened in the last 15 to 20 days after which she was brought to the hospital. So that's why, sir, my first is because it is a continuous illness. Because according to the histories, according to the history,
Hallucinations.
and this could not be
What about the
attributed.
hallucinations? And what ICD-11 has to say about hallucinations?
So out of all of these, according to ICD-11, 2 should have been present. And according to ICD-10, A to D में से 2 होने चाहिए थे, बाकी में से 2 होने चाहिए. एक.
So hallucination, second person का thing.
Hmm.
And whether any other domains. saying कि sleep ज़्यादा थी, वो कहते थे आईडी बिल्कुल आइडल है, पड़ी रहती है, कुछ करती नहीं, एनर्जी लेवल्स नहीं रहती है. What is that?
Consider that as a negative phenomenon.
Huh?
Also, you are in history. Maybe in MSc, history, there are different
There are points, there are pointers for reference, and because acting out was there that she went to strangle her sister-in-law, that she
Those are these
suspected.
because of the hallucinations.
So she was suspecting that it's the sister-in-law who has sent all of these things behind her.
Who told you all this?
The brother, sir, over the phone.
Patient didn't
Hmm.
come up with this.
No, sir. So she did not remember quite a lot of points to an extent. So.
So negative symptoms are negative. What is your take on negative symptoms? Was she asocial? Was she having some evolution?
We do not know the pre-morbid history, sir, in order to, maybe that was her temperament or something to avoid.
What kind of temperaments?
Or
Social avoidance kind of a thing. So those will come only in points against. Base of the points against my
yes.
if you want we don't know. We don't know she was physical personality or push. So we will not be able to, and then when we say paranoid personality, so all these suspiciousness can be because of the paranoid personality. Paranoid personality was already hallucinations. So these are releasing all these become, then the chances of putting your other possibilities are even more when you don't have that kind of a definitive other domains of the issues. Why is psychosis in this?
Because we have presence of psychotic symptoms and more than 3 months. The continuous illness.
So you can at least say points in favor that in history we have a significant history of this, all these phenomena, which can point towards abnormal psychopathology. Patient is usually mental state patient is evasive. We need more mental state examination, serial analysis to establish it. We can't ignore the absence of and the points against me सारी चीजें. What's the we're not sure it's effective or not. Keeping that diagnosis. As she said, you can if one diagnosis, I'm not sure provision of an information in terms of mental state examination is likely to come. Maybe involving a mother will give you more information. So here inadequacy can you can establish. And inadequacy in terms of pre-morbid history is very, very important. Pre-morbid IQ is very, very important. And thirdly, also the illness, giving that kind of information. So with this, if we are still not able to establish a very clear diagnosis, that is that stands your point. your discussion, you want to discuss, put some points, your domestic factors, your plan, your management plan, any investigations, treatment. Part, उसके बाद बता दो some discussion, whatever you are discussing, that is something tends to remain the discussion from here. And then your points in favor. So points in favor, the prognosis. If you are saying she is schizophrenic, most likely. Our evaluation in notice is explained delusions होंगे उन्हें चाहिए इतना लंबा history है 14 साल का history है तो negative symptoms अब आ गए will not be now secondary negative symptoms they are primary negative symptoms you need to basically establish more in the history and I'll tell you husband के लिए ज़्यादा issue negative positive symptoms नहीं होगा what time ये negative symptoms तक काम नहीं करती issue कहते हैं you must be more concerned about it.
Yes.
So, is prepared in a very short period of time. Or they should not have been short. Previous president, last week also was her presentation. Yes,
Why you got two consecutive cases?
for
Why she got two consecutive? Why we gave her two?
I wasn't sorry. I told you. She was just like,
last presentation was far better than before.
Yeah.
Far better than what we did. I also could not attend to much of it because of my control. I don't think you need, well, you obviously everyone needs to improve, but you have made a far better presentation in the last.
Yes.
This presentation could have been better. As Sarah said, it's a total holistic view.
Yes.
Not only the presentation, it's all the family factors, everything. It's a long individual.
So 2 minutes we will take from each of you. Your conceptualization of this. Because otherwise, for Costa, we and me, it doesn't help us. And she knows.
5 minutes.
2 minutes. Very good. This is what we will be getting exams. Because case concepts are for you. Your conceptualization of the things. How you assimilate the biopsychosocials. हम सबसे पूछा जाता था हम सब fuse resonance so beautifully with different aspects of these. Mesmerizing to hear. It's all look secret. I think few days before when I used to attend the press conferences there. Ishan, Dr. Ishani, Dr. Diti, the team with a lot of different versions, and it was very good experience. From times, resonance was years. But you understand the piece. And then what I use. Why schizophrenia? Forget about ICD, onset 22 years of age. Is it an onset for schizophrenia? Ideal age. CTP says 22.8 years. Ideal age. And Boa sense. If कोई भी history, family history of someone turning into a sage or absconding, very likely or likely to be sent into some place, likely psychotic. Continuousness. Persistent dysfunction, even pregnancy. How she takes care of her children, the newborn?
No.
Taking care of the newborn. Or hearing voices. And any physiological change, abnormal or physiologically abnormal or normal change, including with external causes, creativity, economic, activities, even impairment of daily living, especially child behavior. Then having incontinence, not consulting a neurologist or a surgeon, then rather than blaming it on. Very shaky family support because surprisingly, I didn't know this part. I was following. Sadly, I was following this patient for a long period of time. Like her Goa was sent to them. That means families, the own family, the biological family doesn't have that kind of a supportive vision. And now the
But
adopted
sir,
family.
they are supporting her
Financially,
financially,
whether
they
they
are supporting
understand
because
the
the
rules.
maid who is coming to her house for work and paper and then.
Money not paid by the husband.
So a lot of things for the whole stay in this hospital, everything is paid by them.
So we say poor support by the husband. है ना? So when we can say poor support by the husband, husband is doing because
So
maybe the father
husband
is a
is also
teacher.
alcoholic and he'll leave the child with her, knowing
Yeah,
that
alcohol.
So he uses alcohol also. Not an dependence. So not in dependence.
You're supposed to say all this here.
Reported by her brother saying that they took her child from them. The child was taken care by the maternal uncle, so they took the child from them. और वो अपनी मदर के साथ था and he was drunk. मतलब रात को 12 बजे he was not in the house knowing कि वो कुछ भी कर सकती है अपने बच्चों से. Second. He's a man.
So, but he reported not every day, sir.
Any
Episodic
pattern,
use.
Even in your ICD-10 single pattern answer use. So this is important point. And I was showing her poor response, inconsistent response, at times poor compliance, at times developing a lot of sedation and medication, at times getting a lot of anxiety, a lot of stressness. So more or less all the difficulties with the patient.
Husband discontinued the medication informing his brothers.
Support.
And the reason that he gave for discontinuing the medication was I have to go to work and she sleeps all the day because of medication.
Yes.
So I have to.
Yes, or patient evasive. Okay, evasive of the second therapy. That was a graduate, married because she was a graduate.
That was not the reason. Talking to me, and the thing that his brother told me was that he knew about the illness. He knew,
That is
and
what they
what
told.
I like conceptualize is he is not financially that stable, and those
That is what her mother came and told. He informed him and married. Because in marriage to water, that happened when she was in college. They told me, I was not sure. I thought that whatever Shani has put up might be accurate
So he said that I did not know anything about it.
clarification. If he knew and then he has done it, then other vested interests will need to do it. Whether they are planning for any polygamy or something.
No.
Maybe they could.
and the thing that who is controlling their family, his brothers are actually controlling everything. Patients'
The
brothers are
Basuns.
actually controlling.
Keep more of a dependent upon it. And that is why it's separate. That express emotions in terms of husband critical comments, which are hidden, we don't have access to all those. And any abuse in any sense. So ये सब क्या दिखा? Onset she said insidious. So you plan just looking at
So pharmacological, so she was initially kept on injectables and citing increased sedation. We shifted her to tablet haloperidol.
हमारा हो गया आपका एग्जाम में तो नहीं suspended. You say what is your plan and on this information what is your plan?
So since she's maintaining well on tablet haloperidol and we
You said
can
diagnosis.
schizophrenia.
Is it complete?
और भी कुछ लिखा था ICD से
So partial remission so and obesity. You say she's obese. Obesity becomes part of the diagnosis. And they're suspecting TB. So you
Yes.
put it in an evaluation.
सर ये पूछना चाहता है कि आगे फार्माकोलॉजी कोर्स सोसाइटी फैमिली सपोर्ट है तो आगे फार्माकोलॉजी फार्माकोलॉजी तो चलो है फार्माकोलॉजी का क्या देना पसंद करेंगे किस तरीके का क्योंकि बहुत बार 14 साल से बीमारी है उनको पता है दवाई होती है लेकिन बहुत ही कम टाइम लगा है दवाई खाए
We can plan for a long acting injectable.
फैमिली को समझाना पड़ेगा
Maybe a drugs which they can afford and monitoring, and slow titration, side effects monitoring, sedation monitoring, sleep monitoring, biochemical investigation which we monitor. Then FGS, SGS, what do you prefer?
So first generation,
Why?
owing to increased metabolic side effects of
Did she have any metabolic side effects?
obesity and her history of diabetes hair and her HbA1c was raised also. Yes.
Conceptual issues. कितना help कर रहा है? Combination में different machines को you feel छोटे-छोटे indicators नहीं होते जो illness define करते हैं वहाँ से पकड़ लेता है हिस्ट्री से पकड़ लेता है ये फिट कर रहा है ये नहीं फिट कर रहा है ये फिट कर रहा है ये नहीं फिट कर रहा है Pre-morbidly, she was untested. The illness has changed, modified. Pre-morbid illness. The content of the psychopathology is still. Why it is so derogatory? Everything is very derogatory.
Yes.
Is there any sensitivity there? जैसे वो हंसती हैं हम पूछते हैं whether she says it or she is consistent with the account.
So she has been consistent about it.
So maybe if brothers are running the show, why not we call brothers, have them involvement into the treatment plan along with the husband, and go for a family-based psychoeducation, which becomes very important. There's a non-pharmacological component, which is the whole and soul in schizophrenia. Family-based psychoeducation is the most evidence-based psychotherapy till date. Which one we- Which was any other thing which is not possible? Ambiguous certification
ये तो सर हाँ
individual group दोनों आ जाते हैं.
इसका मेरे लिए काफी
And any other forms, non-formal social skills training, which she might have social skills implemented. How will assess social skills when she knows? Assess how much to share, how much not to share. You see her, she appears to be, the skills are probably not there. Social skills training. Then involving her into some kind of environment. Whether that can be done, that can be planned. Rotational rehabilitation. And reinforcement techniques, local economy. The institutions में की जाती है. Management. और अगर hallucinations नहीं ठीक हो पा रही हैं तो of ground truth. Indications happen. First of all, we are taking
So, okay, but the thing is that this type of family who doesn't really want to take pharmacological drug-based treatment, they take ECT, which is such a stigmatizing outbreak in those areas. And I still think the compliance has not been that great.
if I'm not mistaken, she has received ECTs. Right? So we have CCTs. Because the prior psychiatrist, she must have been fine. As far as I remember, what they said, they got to clarify because mother knows, husband doesn't. She was repeatedly taken there. No response to the visit of it. Multiple reports, injection. So your point is, they can consider it. Why? Because patient is very poorly tolerated. The face value here she's tolerating. Then she goes to home, all sorts of side effects come up. Whether inflated or not, over-reported, under-reported, we don't know. Maybe some people later. When she goes back, children lives. So indemnity is not very good. So they agree. We can plan that. Anything else? जैसे नहीं होता भी है बहुत से होता है तो फिर वो
Hello, awareness to you and the application.
so they
But as far as I know, sir, the
DSM-4 glossary has
old where I
it says that is not good. It's a DSM. But that is removed in DSM-5 and DSM-4 TR will be DSM-4.
explanation is there is no one sir but rather than bold directed वो तो है ही explanation मतलब उसका delusion भी explain नहीं कर पा रहा है उसको हम बोल सकते हैं कि
Patient the psychological explain करता है
वो भी एक हाँ
some patient one patient came to me वो चीटियां मारता था जैसे चीटी देखते हैं ना used to grab the चीटी and उसको निकाल के तेल करना बड़ा पसंद था वो न्यू क्यों करता है thought schizophrenic है या कुछ autistic behavior है he was very aroused नहीं cured भी no sir I hear it and I do it ये वाला ठीक सबको मार वो ये करता है one child came used to climb on the walls उसका वीडियो बना के सब लोगों ने वाली करते so ultimately he couldn't tell us the reason why he was climbing the walls and subsequently we thought that it is so initially लगा था कि वो disorganized behavior है उस तरह का वो चलता रहता था but वो बच्चे करते नहीं टीवी में देखते so but something which is not goal directed we have to use our gesture which is very odd तो कहते हैं कि disorganized behavior but I is asking to quote it anything else you have read
तो thing that you told ये जो disorganized thinking ये ICD लेवल में वो ब्रैकेट में दिया हुआ है यही चीज तो सर दिया हुआ है Right.
finally she knows in comments one wants to conceptualize
Sir, actually, in this case, there is a persistent illness for 1 year, and almost there is a biological causes as well as same like psychosocial causes, psychosocial reasons. So we need to deal with the multidisciplinary approach in this case to get a better outcome.
ऐसा बताओ जो हम कर पाए
Except that we need to discuss with like family therapy with the husband, like psychological based to understand to make not more worsening the patient, preventing a relapse, dealing with the family aspect, tell them to avoid the express emotion aspects. to prevent relapse in future. As well as family में कुछ स्टिग्मा भी ज़्यादा है, मतलब फैमिली हिस्ट्री के बारे में हुआ तो बाहर गया क्या है पता नहीं, लेकिन फैमिली में सब कुछ से बात करके
Stigma is more she's saying कि मेड के रखवा दी, फिर अच्छा खर्चा भी करा रहे हैं, सब करा रहे हैं, ऐसे आदमी से शादी भी करा दी तो सब कुछ करने को तैयार है। ठीक है, anything else from this side?
patient wise therapy also is my interview
ठीक है।
She was never compared to any medications. So adequate trials are not made. First of all, we have to psychologically the patient and the family and the patient also. And gets the treatment and in plan along.
Okay, my few takes before we come to the chair here. Like, look, probably very poor frustration tolerance. So, whenever surprisingly she was maintaining well pregnancy, they didn't come to me with unfollowable pregnancy. They were very happy. The motivation to have a child somehow, whether it improved the family atmosphere, whether husband was clearing more, and talk to the husband, he appears to be in some kind of a back pressure to make her fine. Not because he wants to get her. Maybe this is from the his in-laws. A chronic illness, patient having very inconsistent medication intake with surprisingly deviant side effects. And giving you a consistent amount of auditory hallucinations, having some negative symptoms, very poor motivation. So we need holistic effort to sort it out. I would keep her as a chronic schizophrenia because she has had that period of duration of time with very poor family support, very fragile family support in terms of the husband. So we need to have a holistic approach, and we'll be lucky if she responds. I would say. And titrations has to be very consistent. So we are sure that we are not inducing any side effects. So when they come with all this deviant side effect history, we can actually help them subsequently.
So, all the comments are very well taken,
And you sorry, you have represented well. But I didn't attend the last conference. So I think I feel it was given the how they come and tell you the history. It is not a very harmonious experience interacting with them. They want that all some magic stick, everything should be fine. So in that sense, writing the history, verbatim, few things we have try to teach your juniors. So I think as per my expectations, you have been.
so what the crux that we are taking there is very important to tell that the family title system. So under which circumstances was the second marriage? To be appeared that this was a give and take policy. The second husband actually was like he was very indebted to the family of theirs for something that reasons that they have told. Those things has to be assessed whether he is just taking care because he has to go with his job. So unless and until you can have a very motivated caregiver, it's very difficult. Now the whole history again has to be taken in a not in a telephonical manner. So it has to be taken the brothers have to be included because they're not getting the first husband anyways. So those things, after taking those things, I think the founder change management, obviously we are talking about other aspects of the volunteer process, but then again we have to gather whether she has actually received medications in an adequate and in a dose and duration. Those things has to be done after giving every medication and to educate the prognosis and the time it actually takes for the symptoms to subside, the positive symptoms, the negative symptoms, the cognitive symptoms, the affective pain, all the things. So obviously it's very difficult. It's very difficult. Only us doctors for 2 or 3 days and telling them something that we think is scientific. The whole of, I think, 14 years, 15 years, they will be hearing what the society, their society tells them. Okay, so it is very difficult for us to just go and break the shackles in 2 or 3 days. It will happen only follow up is 30 days. So those things has to be kept in mind for society. And the nature and nurture. That's almost basically nature and nurture. So it's the environment, what is the environmental contribution, what is the genetic contribution.